We're going to start. Welcome everyone to the next webinar event in the ClearScript webinar series. This is Kyle Johnson. I'm Vice President of Sales for ClearScript. Want to first of all, thank everyone that's been on the previous number of webinars and welcome all new participants as well. A pretty exciting topic today that's very pertinent in the market, and that's GLP-1s, and the title, whether you're losing money or losing weight, and how the new GLP-1 drugs are affecting your benefit plan. Our presenter today is Yalda Olcott, who I'll give her bio and her introduction before she speaks. But prior to that, we get a selfish plug here from ClearScript as the host of the webinar. So Jill, I'll have you transition the slide, please. We'll do the welcome by ClearScript, GLP-1s, losing money or losing weight. We'll have a questions and answer section, and then we'll talk about what's next. So ClearScript. So ClearScript, we are a pharmacy benefit manager, PBM. We were started by Fairview Health System back in 2005. So we are a wholly owned business unit of Fairview Health System out of Minneapolis, St. Paul, Twin Cities area. 100% ownership, nonprofit health system owned. From a PBM standpoint, we are nationwide. We're national TPA and PBM licensure. I'm actually in Oregon right now, presenting to a couple tribal nations later today, and then a health system tomorrow. So we are national. We're a national specialty and mail provider through Fairview, and we have a national retail network of around 65,000 pharmacies, all major chains throughout the country. We service third-party administrators. A big portion of our book of business is our entities in the healthcare space. So those organizations similar to Fairview, all the way down to critical access hospitals. We have a large number of tribal nation clients and their enterprises. We have all but a couple tribal nations in Minnesota, our clients of ClearScript, and we also service tribal nations really throughout the country in their various pockets. Brokers, from a broker and consultant standpoint, we work with small to large brokers throughout the country. We're heavy in the public sector, specifically school district business, and most of our clients, the large majority, are self-funded companies. Next slide, please. Our services, best-in-class mail and specialty provider and partners, responsive account management. We really pride ourselves on meeting clients where they are, sitting at the table with our clients as more of a partner versus a vendor. We definitely have aligned interests with our clients. A lot of our clients, as I stated, are hospitals and healthcare organizations, many of which have their own mail facilities or specialty ambulatory pharmacy programs, and we help set those up and promote those to drive things internally and leverage their internal fulfillment capabilities. Member-centered service and wellness initiatives, analytics, and actionable data. And it's not just the data we provide, but helping our clients digest that information and put together actionable strategies to positively impact both member health as well as plan performance. And then performance proven results. We pride ourselves on being one of the lowest drivers of cost and trend in our respective market. Next slide. All right, so GLP-1s, losing money or losing weight. I get the distinct honor and privilege of introducing Yalda Olcott. Yalda holds a Doctor of Pharmacy degree from North Dakota State University. She brings over a decade of pharmacy leadership experience, including community pharmacy, medication therapy management, MTM, government programs, and pharmacy benefits management. Yalda's extensive PBM experience includes utilization management, formulary development, clinical program development, and maintaining client relationships. Yalda provides leadership to ClearScript's clinical operations team and is responsible for oversight and the implementation of strategy of clinical programs, clinical services, and product development. So pleasure and privilege to introduce Yalda, and I'll turn it over to you.
Thank you, Kyle. Appreciate that introduction. So why are we all here today, and why is this topic so important? Perhaps, maybe you've heard of Ozempic. This drug went viral on social media and has now reached over 1.3 billion views on TikTok, and I'm sure that number has gone up since I looked just last week. And that's not counting the over 600 million views for Mounjaro and the many others for the medications in this drug class. These medications are being used for diabetes and weight loss, and while hashtag Ozempic's view count goes up, so does GLP-1 drug spend due to the significant cost of these medications. So let's take a look at the next slide so you can see what this phenomenon looks like across various US market segments. Adding to the published outcomes of these medications are celebrities, influencers, ads, national media stories, and maybe even your neighbor raving about GLP-1s for quick and dramatic weight loss. Now it seems like just about everyone you know knows someone experiencing significant weight loss on a GLP-1. These factors have combined to create significant demand for these products, and the result has been a shortage of products for patients with diabetes as well as for those seeking to lose weight. Compounding pharmacies have even started mixing the injectable product to fill that gap, and as a result, at least 4 states have actually taken action to curb compounding of Ozempic's active ingredient over safety concerns. And the manufacturer of Ozempic and Wegovy recently brought suit to challenge this practice with considerations for patent protection and compounding regulations. The graph here shows that utilization. Thank you. The graph here shows that utilization shows quarterly utilization of GLP-1s in 2022. From Q1 to Q4 of 2022, there's a significant increase in GLP-1 utilization across all US market segments. 57% increase for commercial markets, 48% increase for Medicaid, and 39% for Medicare. Which it's important to note that Medicare excludes obesity coverage altogether. So that increase is just from diabetes and off-label use alone. In fact, according to one study, it would cost taxpayers more than $26 billion annually if just 10% of eligible Medicare patients received these drugs for weight loss. In addition to a significant increase in the amount of people using GLP-1s in the United States, these drugs come at a high cost, leading to a 352% increase in diabetes and weight loss expenditures in 2022. So the broader question we have is when evaluating coverage of these drugs for weight loss is whether it's both clinically and economically better to treat certain high-risk obese patients sooner or risk the downstream costs and clinical complexities later. So let's begin by discussing exactly what GLP-1s are and the considerations that should be made when determining if they are cost-effective for employers to cover for weight loss. Next slide, please. So what are GLP-1s and how do they work? They are glucagon-like peptide 1 or GLP-1 agonists, and GLP-1 is a naturally occurring hormone found in our bodies that's insufficient in people who have type 2 diabetes. So for diabetics, these drugs mimic the natural hormone in the intestinal tract by stimulating insulin release, reducing hunger and appetite, and slowing the rate at which food actually leaves the stomach. This combination of effects helps lower blood sugar and A1C, but also causes significant weight loss. The most common side effects of this drug class involve the digestive system. Incident rates are dependent on the medication and the dose, but the most frequent reactions are nausea, diarrhea, vomiting, and constipation. To minimize the initial side effects of these products, they require a stepwise escalation dosage period to achieve therapeutic levels. For example, to reach the full maintenance dose of Saxenda and Victoza, they have the shortest dose escalation period, which is 4 escalations over 28 days, while Mounjaro has 5 escalations over a 20-week period. Some potentially serious but rarer side effects also include acute pancreatitis, thyroid tumors, acute kidney injury, heart rate increases, and acute gallbladder disease. There are also two types of GLP-1 products. There are the first generation short-acting GLP-1 drugs, such as Byetta or Victoza. These were developed first and are dosed daily and primarily used for diabetes today. But then there are also the newer long-acting GLP-1 drugs, such as those you hear about more today, like Ozempic or Trulicity, which are dosed weekly and often used for weight loss in addition to diabetes. As we know, GLP-1s were developed for the treatment of diabetes. So let's discuss diabetes a bit further before we dive into how these drugs impact weight loss as well. We know that diabetes is the most expensive chronic condition that exists today. Meanwhile, 1 in 10 Americans has diabetes and 1 in 3 Americans has prediabetes, meaning that they have elevated blood sugars that fall just below the threshold for diabetes. So that's 100 million Americans living with diabetes or prediabetes today. And in the United States alone, we spend $327 billion annually on direct and indirect costs related to diabetes. These include medications, medical costs, absenteeism, and loss of productivity. Given the prevalence and the associated costs with this condition, it's imperative that we get diabetes treatment under control in the United States. So on the next slide, we'll talk about how we treat diabetes today. Prior to 2021, metformin has always been the first-line therapy for treatment of type 2 diabetes. This medication costs a handful of dollars per month and has been around for many years. However, during GLP-1 drug studies, GLP-1s consistently have shown to reduce major adverse cardiovascular events in adults with type 2 diabetes and to cause significant weight loss simultaneously. Therefore, in 2021, the American Diabetes Association, or ADA, updated their guidelines to include GLP-1s as a first-line therapy for type 2 diabetes, especially for those with cardiovascular risks such as prior heart attacks or strokes, established kidney disease, or obesity. Next slide, please. We know that now that the GLP-1s have a positive impact on weight loss and have been recommended as therapy for diabetics with obesity as well. And in 2013, the American Medical Association officially recognized obesity as a complex chronic disease, and 2023 ADA guidelines emphasize supporting higher weight loss and focusing on obesity as a chronic disease in diabetes management. It's also worth noting that obesity-related medical costs in the US alone are estimated to be near $173 billion per year. As shown in this graph here, the obesity rate in the United States has doubled in recent decades. Currently, 42% of the US population over the age of 2 is obese, which includes 19.7% of US children and adolescents. This means that if we do not change the trajectory of this graph soon, it will continue to rise even further. We know that there are over 236 diseases associated with obesity, and thus can expect to see a continued increase in direct and indirect costs associated with the condition if we continue to let that graph rise. So on the next slide, let's discuss specific GLP-1s and their impact on weight loss. It became evident during drug trials that some of the GLP-1s were also causing significant weight loss in a large portion of the study population. This led to drug trials specific for the weight loss indication as well. And as you can see on this slide, the same active ingredient that was approved for type 2 diabetes was then studied and approved for weight loss. Those approved for weight loss are noted on the slide, which includes Saxenda and Wegovy. And we also know that those in the type 2 diabetes column have been used off-label for weight loss as well. Additionally, Mounjaro is seeking approval for weight loss and has a dual mechanism of action by also activating glucose-dependent insulinotropic polypeptide, or GIP, which makes it even more effective at reducing weight, which is seen in the slide. As a result, we expect Mounjaro will be approved for weight loss and to see tremendous growth in Mounjaro utilization as well. Currently, all GLP-1 drugs approved for weight loss are injectable products, but you'll note there that once daily Rybelsus is an oral product that is a GLP-1 that's currently on the market. Today, it's only indicated for the treatment of type 2 diabetes, but it's being studied for weight loss at significantly higher doses than the doses for the treatment of diabetes today. These medications only take a few weeks to cause noticeable weight loss, and the weight loss peaks at about 12 to 18 months and is maintained while on therapy. As you can see on this slide, the amount of weight loss is quite significant, ranging from nearly 7% average change in body weight to 22.5%. Next slide, please. Considering the significant cost of GLP-1s, which we'll discuss in further detail in the next slide, there are some key components to consider when looking at utilization of GLP-1s for weight loss. We know that only 32% of utilizers are adherent on the medication after just 1 year. And of those, only 27% of those the following year. So some of those adherence barriers that have been identified include side effects of the medication, accessibility due to prior authorization processes, and of course, costs. But why is adherence important? Because studies show that 67% of weight loss is gained back after 1 year of discontinuing therapy. Additionally, the potential long-term effects of these medications for an extended period of time remains unclear, but there are currently multiple ongoing studies being conducted to measure these impacts. Currently, the studies only extend about 4 years, so much remains unknown about these medications, both positive and negative. In fact, just this month, the FDA revealed that it updated Ozempic's label to warn about potential intestinal blockage, which can be a life-threatening condition. Knowing the significant cost of these drugs and the desire for long-term weight loss maintenance, while hopefully not needing to stay on this expensive class of drugs indefinitely, we know it's imperative for patients to implement lifestyle modifications for maintained weight loss and long-term health benefits. Next slide, please. So exactly how much do these medications cost? These numbers can be alarming to look at. A GLP-1 product ranges from $900 to $1,350 for a 1-month supply, depending on the product. According to one analysis, the total cost of GLP-1s used for weight loss went from 49 cents PMPM in 2021 to $5.65 PMPM in 2023. That's an increase of more than 11 times over 2 years, and that does not include the increased cost of GLP-1 utilization in diabetes or off-label use. Next slide, please. It's also worth noting that as more new products continue to be developed with an increased number of indications, we expect to see greater pricing competition and hope to see a downturn in pricing. While we cannot completely avoid the increase in spend from GLP-1s, there are a number of strategies payers can enforce to mitigate some of the rising costs. 4 payer strategies include evaluating whether to offer obesity coverage, utilization management, formulary management, and patient engagement through behavioral management programs. So let's advance to the next slide to begin diving deeper into each strategy. Previously, weight loss coverage was limited in the United States, as many have seen it as a behavioral problem with an associated stigma rather than a disease with behavioral components that can be medically managed and prevented. Additionally, older anti-obesity medications have shown limited effectiveness or significant side effects, and this combination of factors led many payers to exclude weight loss medication from coverage in the past. In fact, as I mentioned previously, obesity is an excluded indication in Medicare entirely. However, since the AMA has recognized obesity as a chronic, complex disease, the rise of GLP-1s and employees seeking GLP-1s as a benefit, we are seeing a shift in weight loss coverage among employers. Coverage of weight loss drugs among self-funded plans ranges from about 33 to 63% of employer groups. Cost efficacy and factors in determining whether or not to cover these drugs and weight loss as a whole vary among employer groups. Some questions to consider include evaluating the overall estimated cost implications of covering these medications, and are there quantifiable long-term savings when obesity is reduced by these medications, evaluating employee retention and tenure and determining whether it aligns with company stance to invest in employees' long-term health, whether coverage for this class of drugs aligns with the organization's broader benefit strategy, such as weight loss surgery, and what other measures can be put into place to mitigate some of the cost implications, as it will be very important to manage costs as coverage increases. While the answer to most of these questions will vary from one organization to the next, on the next slide we can discuss some of the ways to mitigate a portion of these costs. Whether plans choose to cover or not to cover weight loss, it will be very important to ensure utilization management restrictions are in place to control costs. Payers that do not provide weight loss coverage should implement clinical edits to ensure appropriate utilization of products indicated for diabetes to restrict off-label use. Plans that elect to cover obesity should also ensure utilization management restrictions are in place to ensure appropriate use within FDA labeling BMI restrictions. Additionally, renewal criteria can be put in place to confirm a positive response to current therapy in order to approve ongoing therapy. Smart PAs and auto approvals could be considered to reduce prior authorization costs where clinically appropriate as well. Approximately 80% of self-funded groups covering weight loss apply to control utilization. In addition to utilization management, costs can also be somewhat controlled with formulary management, as well as by ensuring the lowest net cost GLP-1 products are on formulary for members. We have learned that medication adherence, patient education, and counseling are of the utmost importance when it comes to determining the long-term value this drug class presents. We know from a previous slide that only 32% of utilizers are adherent after 1 year, and that 67% of weight is gained back within the first year of discontinuation. Prior to taking these medications, patients need to be educated on treatment expectations, administration, side effects, dosing escalations, and management strategies for potential adverse reactions. Throughout therapy, continuous engagement and management of issues as they arise are critical to ensuring patients stay compliant. Therefore, payers should require or incentivize behavioral management programs, as it's critical to provide guidance and support for patients in other areas, including nutrition and diet, physical activity, lifestyle changes, and mental health to ensure implementation of lifestyle modifications. This wraparound support is key to achieving and maintaining weight loss, and these programs typically include a combination of high and low touch interventions to ensure continued patient support and engagement. Some examples of the interventions include live coaching, group classes and challenges, and mobile app capabilities for self-driven results as well. Additionally, according to a Medicare Advantage study, comprehensive behavioral management programs have shown to have a nearly 2-to-1 ROI, and this type of comprehensive support is a key component to achieving and maintaining long-term weight loss, which we know is the main determining factor in the cost effectiveness of GLP-1 use. This brings me to our conclusion, so let's recap what we've covered today. We know that GLP-1 agonists have disrupted the weight loss drug market and offer a new opportunity to address obesity in the United States, but that they come at a significant cost. Additionally, we know that as new indications and products are approved, we expect to see a continued increase in utilization and hope to see a downward shift in pricing due to increased product availability. As we know, these medications will continue to come at a significant cost for employers, especially those choosing to cover weight loss. And there are numerous variables to consider when determining whether appropriate to cover weight loss, such as clinical, economical, regulatory, and patient engagement impacts. And for those that choose to cover weight loss, it'll be imperative to manage those costs through utilization management, formulary management, and behavioral management programs to offset a portion of the increase in spend. On the next slide, we have a list of the resources that are available upon request. We can open up to any questions.
All right, thank you, Yalda. Very informative. We have a number of questions already submitted here, but please feel free to submit any additional questions that you might have. Question number one, Yalda, do you have any additional insight as to why the market, the U.S. has had a consistent increase in the obesity diagnosis?
Sure. The increase that we have seen in obesity that you've seen over the recent decades is attributed to a number of factors, such as other comorbidities, as well as lifestyle modifications, which is why it's so important to have those lifestyle modification behavioral programs in place to help change those habits for sustainable long-term weight loss.
Question number two. I think this is a very good one here. Can GLP-1s be sourced internationally? And I'm assuming that's pertaining to at a reduced cost, but do you have any insight to GLP-1s, whether it's through a Canadian outsource, New Zealand, et cetera?
Yep, they absolutely can. Patients have been attempting to source these products from other countries, such as Canada, whereas there is a reported significant outflow of thousands of doses of Ozempic each month, so much so that the Canadian Health Ministry is trying to explore ways to prevent mass exportation of these products. But in current state in the United States, these medications can be outsourced from Canada as well.
Hey, Yalda, does ClearScript or do ClearScript clients currently cover weight loss or these drugs for weight loss?
Great question. So that is a decision that ClearScript allows each client to make. That breakdown currently is just over 50% of our clients do choose to cover weight loss. And again, there's multiple factors that go into making that decision. So each organization is different in how whether or not they choose to cover obesity, but when they evaluate those various variables, over 50% have chosen to cover it.
Yeah, and that's very, very important to note too, that the majority, pretty much all of our clients are self-funded, ERISA governed plans versus fully insured or state mandated. Question number 4, what do you think the likelihood that the government will require, or what do you think the likelihood is that the government will require coverage of weight loss medications?
That's a really good question. So the Patient Protection and Affordable Care Act doesn't currently consider weight loss medications as an essential benefit. Therefore, it's not required of plan sponsors to cover GLP-1s for weight loss or obesity. But the U.S. Preventative Services Task Force currently is researching whether or not that should change. So there's a research plan out right now called Weight Loss to Prevent Obesity-Related Morbidity and Mortality in Adults. If, as a result of that, GLP-1s are graded as an A or B recommendation, then coverage of these products could become mandatory as a preventative service. Also, there are several advocacy groups that have been asking Congress and the Biden administration to allow coverage of weight loss medications for Medicare. So this could also impact that. We expect that if the administration does change and require weight loss coverage as part of CMS, that would also begin to cause an increased shift in increased coverage among other U.S. market segments as well.
Good question. Yalda, do your clients require programs for weight loss and/or diabetes, and what are some of the components of those programs?
Sure. Yep, they all do. So every client of ours that covers diabetes and/or weight loss requires a PA on GLP-1 products. Depending on whether it is a diabetic product or a weight loss product, those clinical criteria components can vary, but some of those include BMI specifications and comorbidities. For those taking for weight loss, evidence of an active enrollment in an exercise and caloric reduction program. And then we also have renewal criteria, which requires a positive response to therapy before patients could continue on going therapy.
You touched briefly on this, but can you share, does ClearScript currently have a behavioral management program that's available, or what's the ETA on that?
Yep, we do have a program that's available to our clients. Our clients can choose whether to have members enroll in that for diabetes and/or obesity or weight management to help engage those members to control costs and improve their outcomes. With this program, we use real-time data and predictive analytics to identify members and prioritize outreach to come up with the best performance improvement for the plans. And we also provide the plans with tools and reporting to guide them as well through their member health.
Yalda, do you know when GLP-1s, when they'll be available as a generic?
Yep, so the Victoza will be the first to have its patent protection run out, which will actually happen at the end of this year, in the next couple months. So we'll begin to expect seeing generics available for Victoza in 2024. However, Victoza is currently only approved for diabetes, and it is once daily dosing. So we do expect that we'll see an increase in off-label use of its generic for weight loss, but not quite as much as we would with the others that are once weekly dosing and have more dramatic weight loss results. The first GLP-1 approved for weight loss that we expect to become available will be Saxenda, and its earliest date of generic entry could be February of 2026, while the others such as Wegovy and Ozempic and Mounjaro won't be until after 2031.
You just mentioned the term, and somebody had a question about this. For the non-pharmacist, can you just give a brief description of what does off-label use mean?
Oh, sure. So off-label use is when drugs go through the FDA approval process in the United States, the FDA approves them for certain indications or certain uses, which are added to its FDA labeling. However, sometimes medications are used for conditions that they have not received FDA labeling approval for, and those uses are referred to as off-label use. An example of this would be Ozempic, which is approved for diabetes, but it is also being used off-label for weight loss since it has not received an FDA approval for weight loss.
And then I have one more, still waiting for additional questions. Actually, we have a couple more that popped up. If one of the root causes of obesity is lifestyle, why don't employers spend more dollars on lifestyle management modification? I mean, they even put in here it's a rhetorical question, but you want to comment on that?
Sure, absolutely. As noted, it's a rhetorical question. So I think that they absolutely should. I think that since the ADA and AMA has shine a greater light on the importance of addressing obesity as well. We now know that this does need to be treated. And I also alluded to it earlier as well, where unfortunately this diagnosis came with a bit of a stigma and perceived to be more behavioral, but we now know that it is something that can be medically managed and prevented, and that it also is associated with over 236 different disease states and comes at a significant cost to each member's health, but also the country spend as well and our plan spend as well. So I agree that it is really important that that should be prioritized, and we are seeing great benefits from these behavioral management programs, and I think that's the only way to be able to implement weight loss coverage in a cost-effective manner.
And then the last question, I know that this is, we're early on in this, but you mentioned the significant increase in pharmacy spend. Are there any relevant studies showing a decrease in medical spend as a result of the use of GLP-1s, and/or when do you think that information will be available?
Yep, good question. So as I mentioned, there's current studies determining the long-term effects of these medications. So that is the million-dollar question, and the survey's still out and multifactorial, as they're still in the discovery stages of those long-term effects. However, we know that when paired with behavioral management programs, these medications can address obesity better than any other medication available today. And we know that obesity is associated with 236 other conditions that increase medical spend. So it really is a key component of, we also know that obesity is a key component of the most expensive health condition that exists today, which is type 2 diabetes. So if we can manage obesity, then we would expect to see medical spend benefits as well.
I'm just going to take a couple minutes here to leave time for if anybody else wants to submit an additional question. In the meantime, for everybody that's on the call, we still have, well, first of all, thank you for participating in this webinar. We have had like a record-setting amount of participants this go around. So I think it's because of the topic and also because Yalda was presenting. It's nothing to do with me or us, just Yalda. If you have questions, you want to learn more about this program, you can contact any of us, as well as a new addition to ClearScript, Greg Skimp, who's an additional VP of Sales. So feel free to reach out to any of us. I don't see any additional questions, but real good questions. Yalda, it's a privilege and pleasure to work with you. You do a great job and you run a great team. And very, very apropos timing based on how significant diabetes is, as well as, you know, obesity and a huge cost driver. So we appreciate you presenting. We will submit sort of a follow-up additional webinar topics that we're thinking about, hoping that everybody that's still on and those that had to jump off are able to attend our next webinar. We don't know the date yet, but we appreciate everybody's continued support of ClearScript. And once again, thank you, Jill, Rebecca, and others who helped organize this, and Yalda for doing a great presentation.
Thank you for having me.
All right. Well, we're going to give everybody some extra time today. Thank you very much. Happy Tuesday and have a great rest of the week. Bye-bye.